webinars that are presented by the Patients as Partners, British Columbia Ministry of Health, and CCMI. Today's webinar is about quality improvement fundamentals and how they can be applied to doing quality improvement and self-management support. Before I start the presentation, I will hand it back to Troy to do some housekeeping for us, and then we'll get started.
Thanks, Mike. And you could just advance the slide one.
Yes. Let's see here. Okay. There you go.
Thanks. So if you are a returning customer, if you've been in here before, you've seen this, you know what I'm talking about, and this will be a review for you. But if you're new today, I'll just kind of cover the general features of GoToWebinar today so that it's a little bit less confusing for you. The screen you're looking at right now is more or less what you're going to see on your end. You'll have your Windows desktop, and then you'll have these two panes on top of that. One of those panes you'll be viewing the webinar on, and the other one is the GoToWebinar control panel. And the GoToWebinar control panel can sometimes be collapsed when you start the presentation. So Mike, if you could go ahead one slide. And here's what I'm talking about. The orange arrow at the top expands and collapses the control panel. So that will open up the control panel if you want to use the control panel, or if it's in the way, you can collapse it, get it out of the way of the presentation so that you're just looking at the presentation and it's a bit easier to view. So you'll be using that feature, the orange arrow, and then also the question box down below that is also important. We encourage you to use the question box for either technical questions if you can't see the presentation, or if you're having audio issues, something of that nature. Please use the question box and I will field those questions. Also, there will be time at the end of the webinar where Mike can answer some questions. So if you come up with some questions during the webinar that pertain to the content, drop them into the question box and I will forward those on to Mike and he'll get to them at the end of the webinar. So for today, that's all the features that we have, and Mike, back to you.
Okay. I want to begin with reminding people, for those of you that have been on previous webinars and for those of you that are new to this process, that the Ministry of Health and Patients as Partner has 5 strategic areas that cross sectors that they are focusing on from 2015 to 2017. You'll see them on the screen here. They're improving access to primary care and the primary care home model, reducing demand on hospitals by seniors, reducing demand on hospitals by improving care for mental illness and substance abuse, improving access to surgical services and procedures, and improving delivery of rural health services. The conversation that we're going to be having today, or the presentation that you're going to be having today about quality improvement tools, can apply to all 5 of these areas, depending on the initiatives that you're working on. It's important to know, too, that as part of the ministry's work, they have adopted what's called the triple aim, which is basically a very simple concept put together by the Institute for Healthcare Improvement out of Boston that says in order for any quality improvement effort to be successful, you have to have 3 major outcomes. You have to improve population health and have healthy people. You have to have happy people. The experience of care needs to be a good one. It needs to be patient-centered and patient-focused. And it has to be a sustainable system from a cost standpoint moving forward. So throughout the presentation, too, I'll refer to the triple aim in terms of how your quality improvement efforts should keep these 3 major outcomes in mind. I also want to just quickly point out that a major thrust of the work going forward is this notion of a primary care health home. It's been used in the United States called the patient-centered medical home, but essentially where we're moving to is we're hoping that primary care will be the central coordinator working with the patient as a team to maintain their health, manage their care, help them move around the system, and so that it's an integrated, seamless system of care that is transparent to the patient and easy for them to navigate. So it will be an important strategic direction that the ministry will also be taking in the following years. And when we talk about patient-centered care, it incorporates this notion of self-management support. In previous webinars, we've talked about the concepts of self-management support and about shared and informed decision-making with patients. So patients are able to make choices between the treatment options that they have. We want to have improved information and better understanding, not only for the patient with respect to what care they need, but also for the care team to understand what the patient's needs are. And we need the advancement of prevention and health promotion activities to prevent chronic disease and conditions and other key patient issues before they actually happen. The other thing that has been a theme throughout all of these presentations has been CCMI's stepped care self-management support model. And I'm not going to go into a lot of detail about it right now, but it is adapted from the Health Council of Canada's self-management support for Canadians with chronic conditions. And essentially, we see self-management as a stepped care process, depending on where the patient is. At the base here, we talk about being sure that we have a community that is where diversity is addressed properly. Cultural competency is enabled by providers. Health literacy is achieved with patients so that they understand their treatment plans and their prescriptions. The next level up, we talk about goal setting and action planning, activating and engaging patients to set goals for their health that they choose, that they think are important, and the provider facilitates that process by stepping them through how to set a goal effectively and with effective follow-up. We can go up to the next level of care where some patients will really need motivation in order to get engaged in taking care of their health. And that might involve techniques like motivational interviewing, which many of you have heard. And then when we get to the top step, we're talking about very complex care here for patients that might need more than just goal setting and action planning, may need more than motivational interviewing, and may need really a specialty team of care to manage their chronic condition or their situation effectively. So this step care model is something that we, again, is a theme throughout all the presentation. And when you listen to the QI fundamentals part of this presentation, be thinking about where you want to be doing your quality improvement. Is it in one of these steps? Is it related to a particular priority for the ministry? Or is it related to the primary care medical home that you might be trying to achieve in your environment? So the objectives for today are to describe quality improvement, describe the model for improvement, which is a key improvement strategy that is used very widely throughout the world, describe plan, do, study, act cycles, which is part of the model for improvement, and understand how all of these pieces fit together so that you can design a quality improvement initiative that will be effective and likely to succeed. So when we say what is quality, there are lots of definitions of quality. I like this one by Paul Batalden. It is the combined and unceasing efforts of everyone, healthcare professionals, patients, and their families, researchers, payers, planners, and educators, to make the changes that will lead to better patient outcomes, health, and better system performance, care, and better professional development. It's a very nice definition that captures all of the important concepts in what's involved in quality improvement. And who contributes to improving the system? Typically in the past, what we've seen is QI was a department that sat somewhere in your organization. It was people that produced reports for you. You may or may not understand the reports. What we're moving to now is that QI is everybody's job. Everyone from frontline providers right through to senior leadership need to be engaged in QI, need to be able to speak the same language around QI, and it needs to be part of the system's mission and vision and built into the culture of how you do care. So you're constantly looking at the system and saying, where can I improve? Where are there gaps? How can I do better? Rather than continually working in a system that has gaps and may be broken in different places. I love these two quotes, and there's some question as to who did the first one. We often think of Don Berwick as a person that said it, but with a little bit of research, I found out that Paul Batalden was one of the first people to quote it. And it's every system is perfectly designed to get the results, or to get the results it gets. It's very important to remember that. And for those of you that find that a bit confusing, it's an interesting concept in that if you're working in a healthcare system that's getting terrible results, it's perfectly designed to get those terrible results. When we look at the current healthcare system, it really was designed well over 100 years ago when the care needs of the population was really quite different. The care needs in those times were more around acute care, short-term illness, infections, injuries, things like that. But now we have a system filled with a population of people that need good chronic care, need more time, more intensive self-management support, and more resources to make sure that they stay healthy. So part of our bad outcomes that we're seeing right now across our system is not about bad people. It's about a system that was never really designed to handle the type of population it needs to serve now. And then I love this other quote from Edward Demings, a bad system will beat a good person every time. And he said this in the context of not only is it not about people that we need to fix, but when you put good people into a broken system, they get worn down, they get tired, they get burnt out. So we're really talking about system quality improvement here, not about person quality improvement. In order to have successful QI, we need to have these three key ingredients: will, ideas, and execution. And Tom Nolan said it nicely in that you have to have the will to improve, you have to have the ideas about alternatives to the status quo, and then you need to make it real. That's about execution. So we have the will, the ideas, and the execution. These are absolutely important because I've seen many quality improvement projects where frontline folks may start a great quality improvement project, but there's no will by the organization to actually move to it. So they end up becoming an island of improvement inside a much larger system, and typically their quality, their improvements will evaporate over time. So all three of these pieces are extremely important. So how do you get started? Again, Jerry Langley here has a nice quote. Many authors and experienced improvers have recognized the importance of an organization having a consistent framework for conducting their improvement initiatives. This consistent and structured approach offers a common language and allows improvement teams to be formed from different departments and groups in the organization. As well as accomplishing a specific improvement, participants following the structure become better improvers. So I mentioned this a little bit earlier about this common language, and we have to have a way of talking about quality improvement the same way so that we're all using the same processes, using the same tools, and not either duplicating work or missing each other because we're using different approaches. I would recommend to everyone that part of getting started in your quality improvement journey is to read the Improvement Guide. This is a fantastic book which gives you everything soup to nuts around quality improvement. It talks a lot about the model for improvement that we're going to be discussing shortly, but it also gives you all sorts of tools around how to analyze data, other improvement methodologies that may be appropriate for what you're doing. So I'd hesitate to say it, but it's the Torah, Quran, Bible of quality improvement. So I mentioned the model for improvement. Let's take a look at this. This model was developed by Associates for Process Improvement and has been used extensively by the Institute for Healthcare Improvement, probably going back to possibly even the 70s. It's really gained traction in the 90s and the early 2000s in quality improvement in healthcare. And one of the reasons it has gained so much traction is it allows us to test ideas. It allows us to sort of get our hands dirty with the system that we're trying to improve without rushing to implementation, without jumping into a full-scale implementation and having that go south on us very quickly. So this allows us to look at our system on a smaller scale, test things out, and build our knowledge as we go until we get to the point where we're convinced that we could implement this on a large scale and we would have 0% failure. It starts you off by asking 3 simple questions to get you going on your quality improvement journey. What are you trying to accomplish? How will you know that a change is an improvement? And what changes can we make that will result in improvement? And then below that is a Plan, Do, Study, Act cycle, which is a rapid cycle tool or technology for testing ideas on a small scale, building knowledge, and building to the point where you can implement. There are all sorts of other quality improvement methods, and we don't have enough time to cover them all here in this particular webinar, but I think it's important to know that they're out there. You can see the list here. They all have different histories. They do different things for different types of quality improvement initiatives. So I would urge you to look at the improvement guide and get some background on some of these, so that you can decide which is the best tool for your quality improvement effort. So why are we talking about the model for improvement? Well, it's good for small projects, and it's good for projects on the system level too. So it can be used across a wide variety of organizations. It's been used in manufacturing, other sorts of IT technology, as well as healthcare. And it uses this iterative approach to learning that I mentioned earlier. It allows you plans to adapt based on that learning, so that rather than creating a full-scale implementation plan, having it fail, you can actually say, well, if we had tried to implement that, by testing it, we learned it doesn't work very well. So you can build the implementation plan from experience, not just from guesswork, or not necessarily just from best practice, because you need to test it in your own environment. It helps avoid that rush to implementation. I don't know how many of you have been on quality improvement planning committees, but usually the approach to planning is to develop an implementation manual that has all the T's and crossed and all the I's dotted. And then, as I say, and I'm sorry to be a broken record on this, but when we get to implementation, there's something we've forgotten, something we've missed, or something that was unexpected that can derail the implementation, stall it, cost more money, but it had a cost or a side effect that was unexpected. So the model for improvement allows us to do testing, to learn those lessons on a much smaller scale and build our knowledge towards a sound implementation plan. It promotes teamwork, working together. It's you haven't got a QI person working in isolation. It involves the whole system, and it's pretty simple in its concept. It's pretty intuitive, and you'll see that as we go through it. So let's take a look at each of the three questions, and we'll start first with, what are we trying to accomplish? Quite often, I know I've been involved in quality improvement efforts years ago that didn't really have a clear aim as to what they were doing, so we really weren't quite sure what we wanted. We knew that something was wrong, we knew that something needed to be improved, but we really didn't sit down and articulate what we thought it was that we needed to do. So an aim provides that focus and promotes an alignment of all the efforts towards that particular aim. It's, as I said, it aligns with the organization's mission, vision, and values. It's developed collaboratively by a team, so you get inputs from all different parts of the system that are looking at and holding different parts of the elephant. It's clear and specific, so it's smart in its approach, that it's specific, measurable, actionable, relevant, and it's time-bound, so it doesn't go on forever. And it can be communicated easily to others. We often use the term the elevator speech. An aim statement usually has enough precision that if you can communicate it within 30 seconds to a colleague, they will have a very good understanding of what it is you're trying to do and what you're trying to accomplish. So here's some examples of not so good and good aim statements. The British Columbia Coalition for Patient-Centeredness will support patients to improve their health by ensuring all patients set goals and action plans. On the surface, it looks great, but it really doesn't tell us much about what they're doing. We know that they're interested in making sure that patients are supported in their self-management, but that's about all we know. A better version would be one that says, the British Columbia Coalition for Patient-Centeredness will improve patient self-management with a pilot of 100 chronically ill patients at ABC Clinic over the next 6 months. So you can see how we're getting specific. You can see how we're time-bound. The coalition will work with one practice team at the clinic and train providers in a variety of self-management support techniques that increase patient confidence when managing their health. So we're getting very relevant to the topic of self-management and what providers need in order to better care for their patients. There will be an emphasis on building brief action planning into the clinical visit. The primary outcome for the pilot will be to increase patient confidence by 50% over baseline. We now have something very measurable. So other measures may be may include reduced urgent care and ER use and increased provider job satisfaction. So you can see how specific, measurable, relevant, in time this is. Actionable, sorry, I forgot the A in there. And it certainly gives you a very good idea of what the British Columbia Coalition for Patient-Centeredness is trying to do. So that's the level of detail that we like to get to in an AIM statement. Sometimes you'll be working on it, you'll know that there's something wrong with your system, but you don't know what's really wrong with your system. You sense that there needs to be improvement somewhere, but you aren't quite sure where it is. These are 4 tools that can help you identify what are the root causes of the gaps that we see in our particular system. Again, I don't have time to go through all of them. Again, I point you towards the improvement guide to read about these different tools which help you get to the root cause and then be able to better target what your quality improvement initiative is trying to accomplish. Let's look at the second question in the model for improvement. How will we know that a change is an improvement? This is about measurement. We can't improve something that we can't measure. So measurement is really a critical aspect of any quality improvement effort. Again, a great quote, if you aim at nothing, you'll hit it every time, attributed to Zig Ziglar, sorry. Measurement tells us whether we're hitting the target or not. How does it help us in improvement? It helps us to answer our initial questions as part of our aim statement, to understand if the changes are contributing to reaching our aim. So, you know, I've been on in some projects where we're testing changes and we think they're the right changes to do, but when we actually go about measuring to see if they made a difference, they actually didn't. They were good ideas, but they didn't make a difference with respect to the aim that we had laid out. Helps us understand our progress, it compares performance with similar sites so we can learn from other sites. It helps to identify unexpected outcomes. You know, I read in the literature that A leads to B, but when we tested in our system, A leads to C. So you get the measurement is very important in letting you know what's actually going on in your system. And it lets you know, obviously, when your aims are reached. I'm not going to spend a whole lot of time on this, but I think it's important to recognize that there are different types of data, different types of measurement that we go about doing. There's improvement, measurement for improvement, measurement for accountability or evaluation, and measurement for research. Each one of these require a different level and actually a different rigor of data that goes into them. For improvement, we have to be okay with what we call just good enough data. Just enough data to let us know that what we're doing is actually making a difference. On the other end of the table here, research would require that they collect what's called just-in-case data, enough data to make sure that the change that they're testing is truly either cause and effect or truly correlated with their hypotheses. And then accountability might fall somewhere in between their evaluation, depending on how rigorous you want to be with what you're evaluating. There's a second part of this table which talks about sample sizes and hypotheses and testing strategies. And you'll see when you go through the table that the level of importance or the orientation around these concepts is very different whether you're doing improvement, evaluation, or research. So as I said before, for sample size, we get just enough data to know that is what we're doing, changing things. It's flexible. Our hypotheses are flexible. In research, they're fixed. You can't change the hypothesis in the middle of a research study, but we can in improvement. Testing strategies, we typically do sequential tests. So we try something, learn a little bit, try something built on that. But in research, it's one large test with one large data collection. So I just want you to be aware of the differences between those kinds of data. And when you're looking at a quality improvement initiative, improvement data is probably good enough. It may fly in the face of some of your scientific training, but I think once you get doing the testing and realizing that good enough data is good enough for you to continue moving, it'll help prove to you that you don't actually need a randomized controlled trial to do quality improvement. The principles of measurement for quality improvement. Improvement data is useful for learning, obviously. It answers our questions, helps us understand our theory. The data is often useful but not perfect. I'm repeating myself here. I think the important thing to take away from this is that many of the data that you collect during quality improvement are simply observational data. You tried something, you maybe had someone on a healthcare team try taking people's shoes and socks off during a diabetic care visit, and lo and behold, the feet get examined when normally they would not be examined. So you're looking at what's actually going on. Observable data is equally as important as quantitative data. And as I say in the last year, frequently includes a mix of qualitative and quantitative data. When people are embarking on quality improvement initiatives and using the model for improvement, we recommend that they have 5 to 8 measures that give an overall view of the system performance. And the measures are a mix of measures. They can be outcome measures, process measures, balancing measures. We recommend that in that 5 to 8, you have at least one of each. And it ensures that the measures are coming from the system and are actually pertaining to what your aim statement is and the changes that you're trying to make. Let me talk a bit about the 3 different measures. When we talk about outcome measures, it's the endpoint or goal of a process. If it's a clinical one, it may be hemoglobin A1C level for the population. It may be blood pressure levels for a hypertensive population. It might be, in the case of self-management support, it might be percentage of patients with a documented self-management goal and action plan in their record. The key thing here is your quality improvement effort is trying to improve a final outcome for the patient population. When we talk about process measures, these are the steps or tasks that are required to get to your final outcomes, your goals. So examples would be, well, I use documented self-management goals here also because that is actually, in this case, is a process measure for getting to the goal of improved patient confidence, improved patient self-efficacy. Biannual blood glucose testing for patients living with diabetes, preventive care cancer screenings to prevent cancers, efficient referrals or patient handoffs so that patients move between care providers more effectively, the outcome being integrated, coordinated care. All of these, again, these measures are tied directly to the triple aim, as you're seeing on this slide, where we're trying to improve population health. We're trying to improve the experience of care while being cost-effective at the same time. And then the third measure are balancing measures. Now, these are ones that are sort of your guess at what you think might happen to the system when you try changing it, and you're trying to make sure that you capture any unintended or unexpected impacts on the system or things that might work against the quality improvement. Examples might be provider satisfaction. So you may produce one of the most effective, cost-efficient care teams, but it takes them 16 hours to get through a day, and provider satisfaction is very low, even though patient outcomes experience is high and cost is reduced. So if provider satisfaction is low, you're not going to have your providers around very long. So that would be one way of measuring an unintended consequence. Maybe you've developed a great system that is evidence-based, it's delivering fantastic care, the patient experience is terrific, but it costs too much. Or it could be that you're working with patients and you're trying to achieve clinical goals with patients and working very hard to titrate medications and ratchet up treatments and actually end up harming some patients. So these you've got to keep in mind when you're doing quality improvement that your changes, even though they may look like they're doing a great job in your measurement, may have unintended consequences and unintended impacts. So make sure you have some balancing measures that you think make sense. When we talk about defining measures, we have to be very clear about what we mean. So it's one thing to say we're going to collect data on a body mass index. Well, what does that actually mean? What does it mean to collect data? An operational definition tells you what the concept or construct means. It clearly defines what the concept is and tells you exactly how to measure it. So in the case of body mass index, you have a very clear algorithm of how you go about computing that. And I'm sorry that the algorithm escapes my mind right at the moment, but clearly it's a combination of height and weight. and you know exactly how to measure those things. And so I can give you that algorithm for body mass index and be sure that if you go out and do it on 100 people, you'll likely do it the same way each time. So an operational definition gives you a very clear way of how you collect your data and collect it the same way at the regular intervals that you'd be collecting data for your quality improvement project. So if you have a measure like percentage of patients with a hemoglobin A1C less than 7, or a measure of percentage of patients that have attained their self-management goal, you've got to be very specific about where you get that data, how is it used, how is it aggregated, when are you going to get it, and make sure that it's done the same way each time. When we talk about displaying improvement data, there are a variety of ways to do it. There are pie charts, which basically shows the contribution of each change and on the total package of the system. So you might have a variety of different changes, and you can say X change contributed this percentage of improvement to the system. You can use bar charts, which show values across a number of different categories. And you can use line charts, which show the measure and the process behavior, the measurement behavior over time. And that's the one that we typically use when we're using the model for improvement and doing quality improvement along this approach. The run chart is a really nice way of observing your data over time. So unlike a bar chart that is before or after, and you can say, you know, I did this to the system in December 2015 and December 2016, I had 50% improvement. But you really don't know what happened in between, and a variety of things could happen in between. The system may have been improving on its own already. It may be that the system never improved at all during all of that time, and then there's a big spike right at the end. So the run chart gives you a nice visual display of what's happening with your measures as you start making changes to the system. There typically isn't any calculations required, although you can get very technical with run charts, and again, the improvement guide will give you information on how to do control charts and a variety of ways of analyzing run charts to see if the change that you're making is truly a change. You basically plot the measure of whatever you're interested in on the y-axis and the vertical axis, and plot the time across the x-axis on the bottom. And you add your data points at whatever interval you're doing measurement, whether it's monthly, quarterly, whatever it might be. And you often look at the medians of your data over time to get a sense of where did the change really start happening? Is the change really a change over time? And again, you can look at the improvement guide for interpretations of how to use medians and understanding the data points before and after a median. I just use this as an example. It's very telling. So we have a particular quality improvement effort that's looking at effective hospital discharges, and effective being the percentage of rural seniors discharged with discharge plans sent to the primary care provider within 2 business days. So if we take a look at the dark green line, Hospital 1, we'll see that what happened with them was they were very interested in the idea, they got going on it, but the project didn't have any resources. There wasn't an organizational directive to do it. And as they got into it, they ran into all sorts of problems like consultation notes not being ready. They couldn't get the notes done more quickly. They couldn't get the discharge people to do things differently. So they, in this case, they literally had a good idea, but they didn't have the organizational will, and they didn't have the execution on the ground in place. Remember, will, ideas, execution. Hospital 2, we look at this one, they soared right off the bat. In this particular case, their CEO put this as a top priority for the organization. The quality improvement group were able to test ideas, and people were on board with testing the ideas. And when they finally developed a good process for making sure the discharge plan got to the primary care provider, they were supported in spreading it throughout the hospital. So they had all 3, will, ideas, and good execution. And then you look at Hospital 3 and you say, well, that's weird. They did really well, but then they all of a sudden did badly, and then they did well again. In this particular case, what happened was the organization had the will, ideas, but they lacked a little bit of execution. They didn't have someone cross-trained in the discharge process, and so the discharge planner that was being used in the pilot got sick and had to take a medical leave, and there was no one to replace the person, so nothing got accomplished for almost 6 months, which is why they went back down to 0% of discharge plans sent to primary care. So the run chart tells you a story, and a better story than you would get from a before-after kind of description, or even from a pie chart view. So that's why we like to think, we like to encourage you to use these time series run charts to be able to tell your story of quality improvement. I talked a bit about interpreting data and run charts. Again, there's all sorts of information in the improvement guide around how to analyze runs of data, how many data spots in a row represent improvement, shifts in data, trends that you can see, astronomical data points that are off the chart. Again, I encourage you to look at the resources that you see on this page to read more about how to interpret run charts. Now we get to the final part of the 3 questions, that is, what changes can we make that will result in an improvement? How do we come up with changes? You know, changes are good ideas that we'd like to be able to test to see if they work well in our system and result in improvement. You can think logically about your current system and develop some ideas. These are pages in the improvement guide where you can go read about it. We can benchmark and learn from other organizations that are doing well. We can use technology that gives us ideas about how to incorporate information technology and other technologies to improve the system. We can do creative thinking. We may have a new problem that no one else has tackled, and we just try creative ideas and test them. And you can use change concepts. Now, what do I mean about this thing called change concept? It's a general notion or approach to change that has been found to be useful in developing specific ideas for change that lead to improvement. So, for example, a change concept is support patients with their self-management. That's a global change concept that's very important, and 20 years ago was unheard of in healthcare. So when we would go out to systems in the 90s and say, you need to deliver self-management support, people would look at us and not really know what we were talking about. So the change concept leads to ideas that give you something to test on the ground. So some of the ideas around supporting patients with their self-management might be to use brief action planning, which you heard about in a previous webinar. But for those of you that are new to this, it's basically a very rapid algorithmic way to go about helping patients set a goal that they choose for improving their health and an action plan related to that goal. So some of the ideas to test would be using brief action planning in a clinical visit, try patient engagement techniques, maybe use ask, tell, ask, which is a way of giving patients advice without forcing the advice on them, but actually engaging them in giving you permission to tell them what you know about and asking them what they think about your information. So that's how we move from change concept down to ideas for testing. If we have a lot of different change concepts, we often call it a change package. So they're a collection of those good ideas that are ready for use. They're known to bring about improvement. They have a proven pedigree, either based in research results, clinical guidelines, for example, or experience or best practice. And they're usually organized around some kind of model or framework. So for those of you in BC, you've been using the expanded chronic care model for a number of years now, which is a model for how you go about revamping your system to deliver better preventive and chronic care for patients. We showed you a model early in this presentation, the stepped care model for self-management support, which is a model of a collection of good ideas about how you can go about supporting patients in managing their health. Now we get to the PDSA cycle. And this is the final part of the model for improvement. The PDSA cycle is almost counterintuitive, but it isn't. It's intuitive and counterintuitive at the same time. It's essentially the scientific process distilled down to its core elements. When we do a PDSA, what we're trying to do is test an idea, one of those ideas from a change package, and we want to test it quickly and learn quickly and then move on to the next PDSA so that we can build our knowledge sequentially to the point where we're ready to say this change is good to go live implementation. In the PDSA, we start with a plan. We have an objective, something we want to learn. We have questions, things that we want to understand about this meeting this objective. We might have some predictions about how we think this test is actually going to go. And then we develop a very clear plan. Who's going to do this test, on what day, at what time, with how many people, and how are they going to, sorry, I said when already, so who's going to do what, where, and when. Then you carry it out. You carry out the plan, document any problems and unexpected observations to get ready to begin to analyze the data. And when I say collect data, most of it's observational. The example I gave of having someone take off shoes and socks patient, you can watch that process with 5 patients and learn an awful lot about, is that a good way to go about getting foot exams done for patients living with diabetes. You study the data. So maybe, again, using this example, or let's use an example of setting a goal with a brief action plan goal with a patient. You watch 5 of those, and you can see very quickly where the idea needs some improving. That is, maybe the person doing the brief action plan wasn't trained well enough. Maybe the patient didn't understand. Maybe the patient understood, but halfway through the process, the patient got stuck, didn't know what to do, and the provider started to tell them what to do, which is what we don't want to have happen. So you look at the data and say, okay, it wasn't a perfect PDSA. There were still some things that didn't go quite right. What do we want to do next? And that's the act part. And that is, do we want to make changes to the current PDSA? Do we want to get rid of it? Just it was a bad idea right off the bat, failed completely. And if we want to change it, what's the next cycle going to look like? So you start the process over again. You collect useful data, not perfect data. Just want to keep reminding you that the purpose of the data from a PDSA is to learn, not to evaluate. And observation is often the mechanism for gathering the data, using qualitative, not rather than waiting for quantitative. Now, just to expand on that a little bit, people go crazy when I say, why don't you just test that with 2 patients? That will tell you an awful lot. They'll say, well, two isn't good enough. You need at least 50 or 100 to get any kind of reliability. That's if we were doing it for research purposes and maybe evaluation purposes. Here we just want to see, we just want to watch that test happen in real life and see what we need to do differently to make it a little better. So we can keep testing on very small numbers and learning until we're pretty sure the process works properly. You record what went right, what went wrong, in order to study the data and determine how to act next. That's the PDSA piece of it. We build on that knowledge. I kept saying we build sequentially. So here's an example of improving self-management support for patients living with diabetes. And our objective is, can brief action planning be integrated into the clinical visit structure? So the objective is to improve self-management support. And the question we have is, can brief action planning be integrated into the clinical visit structure? One of the first cycles is we try having an LPN use brief action planning before the MD portion of the visit. And they try it with 3 patients on Tuesday. And what the LPN found was that the patients didn't understand what was going on. They wanted to talk to the doctor. This sounded like pretty weird stuff to them. And so the ACT part of that PDSA was, well, we need to get the physician involved somehow because the patients were confused by this process. So the next PDSA was, why don't we get the MD to do the brief action planning? And so the next day on Wednesday, the MD tried doing it with 3 or 4 patients. And while she found it useful and a great tool, she didn't find it the best use of her time given all the clinical priorities that she had with these patients. So we look at that and say, okay, this brief action planning still seems to be a good idea. We're just having trouble with some execution. Cycle 3, they have the LPN use brief action planning after the medical provider introduces it to the patient. So there's a handoff to the LPN. And what they find is that works very well. Most of the patients made a plan. There was one that just refused to, didn't want to have anything to do with it, and that's fine. You let them go. You don't force it down their throat. So that prepares us for cycle 4. We're kind of okay now with the execution of this and say, but let's test it with a few more patients under different circumstances. Let's test it on a Monday, which is crazy in our practice. Let's test it in after after hours or weekends, just so we know it works under different conditions. And they find that in cycle 4 that it's working just about any time that they use it. So now they're at a point where they can say this brief action planning process of the doctor introducing the concept and the LPN following through doing a brief action plan is probably going to work with all of our patients. And so now they're ready to implement. And you'll see what happens is that what would typically be a 1 or 2 year planning process in typical healthcare planning, you might see that within 6 months, 70% of appropriate patients have documented brief action plans in their record. That's the kind of accelerated change that we're talking about when we talk about the model for improvement and using the PDSA technology. So again, you can just see from this is sort of tying it all together. So what we have our aim statement. We want to do this with our current system and fix this. Here are our measures, how we know that a change is an improvement. Here are our measures that we're going to use to monitor the process. We have a bunch of good ideas from research evidence and best practice that we're going to try testing. And then we're going to have our theories and hunches and best practices and begin testing down at the bottom part of that ramp. We learn something from the first test, which leads us to the second test, third test, fourth test. We're learning and improving as we go at the same time. That's something very critical here. You're improving while you're learning, testing under new conditions, and then finally you're ready to implement a change because you know that you'll get breakthrough results. You know that if you put this change in place in the system, it will produce the desired outcomes, and your system will be perfectly designed to get those good outcomes that it's getting. Okay, that was a whirlwind tour of the model for improvement and PDSA technology. I threw awful lot at you there, but there's also a lot of resources which I really do encourage you to go and look at to round out your knowledge about PDSAs. But we do have some time for questions, and so I'll let Troy manage any questions that we have from folks.
And I'll give you all a minute to respond. I'm watching the question box now. I've got one here for you, Mike. Can you talk about the time involved to do these pieces of work and how to ensure leadership is on board and supportive to ensure space is created for? I hear you say accelerated cycles. Does it take time to adjust?
Let me take a stab at that. I think there's a couple of questions in here, and hopefully I understood you. Let's talk about leadership first. If you have a part of the system that's not working well and you want to do quality improvement, the best thing is to find out from senior leadership, is this a priority for them? And if it is a priority, are they willing to stand behind it and help you remove barriers as you encounter them? Because as you start testing changes in the system, you encounter a variety of different barriers. Whether it's time issues around implementing the change, or cost issues, or you might have a protocol or a rule in place that needs to be removed in order to test different changes. So you've got to engage your senior leadership to the point that they are backing the initiative and are willing to remove those barriers. When we talk about accelerated change, what I'm really talking about there is we want to be able to do quality improvement and get change quickly. Traditional quality improvement tends to involve planning, steering committees that have a hard time meeting, as I say, they tend to move towards implementation. So there's extensive literature reviews, there's extensive documentation of the process that's to be implemented across the system, and it's usually a long time before implementation. It's important to know PricewaterhouseCoopers did an analysis of 10,000 businesses that did quality improvement initiatives, and less than 2% of them delivered the desired business outcome that was looked for. And that was because almost all of them rushed to implementation without testing testing things that would derail the implementation in the long run. So when I talk about accelerated change here, to be able to test on a small scale and learn something about how to test it better, at the same time, those tests that you're doing are impacting the measures that you're using to track the impact on the system. So not only are you learning, but you're improving at the same time. Not sure if that second part answered your question. If it didn't, please say more. If any of my CCMI colleagues are listening in, please feel free to chime in with suggestions and content that I may have missed.
I'm not seeing anything else in the chat box there, Mike.
Well, I've either been perfectly clear or clear as mud. Hopefully the answer is somewhere in between there. Troy let me just advance the slide here. We do want to talk about next steps. I really do encourage that you try this PDSA technology. It's very hard to hear it in theory, and there's a lot of jargon involved in it, and I hopefully have tried to de-jargonize it a bit, but try testing it. Try testing it even in the absence of a quality improvement project. I actually use it with my kids. I'll tell a very quick story. My son was trying to learn how to play hockey, and one of the things he wanted to do was a slap shot where the puck came off the ground. I actually didn't know how to do it because I was a terrible hockey player. But I was watching him in the garage sort of slapping away at this puck and slapping and slapping and slapping, and nothing was happening. And I realized that when it comes to PDSAs, he was doing plan, do, plan, do, plan, do. So he never stopped and studied what was actually going on. So I've got him to do 2 or 3 more shots, and I said, pay attention to the way you're using your stick. And so he stopped and he studied after a couple more PDSAs, and he said, I think it has something to do with the angle of the stick. And I said, well, what do you want to do? And he said, well, maybe I'll try angling the stick a little bit each time until I get one that gets off the ground and see if that helps, which is exactly what he did. So he tried 3 more PDSAs, 3 more slap shots. The third one came off the ground, and he paid attention to the angle of his stick. So he then started more PDSAs using that same angle and was getting about a 90% lift off the ground rate very quickly. So PDSAs are things that you can use in all aspects of your life, not just quality improvement. So I encourage you to try testing them, using them on a regular basis, get comfortable with them, so that when you go into a quality improvement initiative, you can explain them to your colleagues that may not be familiar with it, and explain the need to go through this process of creating a good aim statement, having a good measurement data set, and a good set of ideas to test, and a testing technology that helps you rapidly learn. The next webinar we have is going to be on motivational interviewing. It'll be presented by Alice Domes and Jenny Spring. That'll be October 12th, once again, from 12 to 1 Pacific Standard Time. And after the webinar today, you'll receive an evaluation form to give us some feedback. We really do value this feedback. We hope that you would take the time to fill it out. We use our feedback to improve our presentations each time because like anything, we're constantly improving. So please take the time to fill out the feedback form. It's not too onerous. Troy, is there anything you need to say to wrap up?
Nothing from my side. Thank you all for joining.
Yeah, thank you very much, everyone. And again, if you have questions after the presentation, my email is there. Please feel free to email me, contact me, and I'm happy to answer any questions that you may have. Thanks very much, everyone. Have a great evening.
Thanks, everyone.